the Across project, along with Professor Imran Chowdhury, who has just put himself on camera. Imran's based in Karachi, and I'm actually traveling today, so I'm actually joining you from Madrid. So it's very nice to have you today for a couple of reasons, not least of which is this is the first of what will hopefully be a termly program of seminars that we're going to be running as part of our Across program. But actually also this Sunday happens to be World Heart Day. So we've tried to coordinate this seminar in particular to line up with that. Now I'm just going to share my screen if I may, and I'll just give a couple of brief introductory slides. Okay, so I think you're all aware of this, but just so everybody knows, Across is an acronym for the Affordable Cardiac Rehabilitation Outreach Interdisciplinary Strategic Study. And the idea of Across is to develop a culturally acceptable and contextually adapted, affordable home-based rehabilitation program based on existing interventions that we have in the UK for people with coronary heart disease or heart failure in Bangladesh, India and Pakistan. And we're particularly keen to extend these interventions to take account of people's multimorbidity, in particular their depression and anxiety. The project is, I'm delighted to say, got many partners. These are not all the partners, so if you are a partner and you're not on this logo slide here, don't take offence, please. But this is just to say that we're blessed with a number of partners across UK, across South Asia, and the NHS in UK as well. And last but not least, also delighted to say that for those of you who are coming back into the group, having been away for a while, you will know that we got our approval for the Across programme to be funded over the next 5 years by NIHR. We still can't say that completely officially yet. We've got to sign contracts, but obviously we're hoping to do that very soon. But we're absolutely delighted that we're in a position now to be able to move forward with this 5-year project, having secured the best part of £4 million worth of funding. So it will be a 5-year journey, and this is just to remind you what we are going to be doing practically over the next 5 years. 4 work packages, 3 empirical work packages. The first one will kick off very soon, and actually Jamal, who I'll introduce in a moment, his presentation is very timely because he's going to talk about his project, really, which has been a miniature version of Work Package 1. Once we complete Work Package 1 at the end of our first year, we'll move on to an external pilot trial. And then last but not least, we'll hope to do a full multi-centre randomised control trial in each of our 3 South Asian countries in the last 3 years of the programme. And of course, these projects are not only important to deliver research knowledge, but they're also to try to develop capacity that outlives, if you like, the research investment. So both research and clinical research capacity we'll be developing, and that's a work package that's led by both Amy and, in fact, Jamal, who I'm going to introduce to speak today. So again, just to say, happy World Heart Day to you all when it arrives. Do go on to the World Heart Day website. They currently have a sign up. So this is part of a global endeavour to try and make sure that decision makers are aware of the importance of heart disease. So do go on there and sign up to their mandate. I'm getting a little bit of feedback, so just check that you are on mute if that's okay. So on that theme, we are going to record today's seminar. Please do keep your video off and audio muted. That's probably going to be easier. I know you're all on camera just now maybe, but do put yourself off camera. There will be an opportunity to ask questions at the end of today's seminar. The seminar will be about 30 minutes long. So do put your questions in the Q&A function. And we'll monitor those as we go. And then if there's time, we'll also give the opportunity for taking questions live. So put your virtual hand up if you've worked out to do that yet, and ask a live question, or just put yourself on camera and wave at me, and we'll take the questions. So I think without any further ado then, it really is my pleasure to introduce Jamal Uddin, who's going to give our seminar today. And it's a blessing for me, actually, 2 times over. First of all, I've got the pleasure of being the main supervisor for Jamal's PhD. Jamal's a registered student at the University of Glasgow, but based in Bangladesh, where he has been practicing as a physiotherapist for a number of years and really taking a leadership role in the availability of cardiac rehab in Bangladesh. Everybody in Bangladesh who's in the cardiac rehab world knows Jamal. He really has been a leader. And then the second pleasure is that Jamal is also one of our across team. And as I mentioned, together with Amy, is going to be leading our capacity development. And of course, capacity development needs to be led by our leaders of the future, not the old guys like me. So it really is a great pleasure, Jamal, to welcome you to this seminar and ask you to kick off our seminar program with your presentation today. Over to you. Thank you.
Thank you, Rod, for your brief introductions. I'm very blessed. So, thank you so much for everybody, and very warm good evening from Bangladesh. Today I'm going to present actually the adapting the Bangla Heart Manual in Bangladesh, the lessons learned, opportunities and barriers what I faced throughout the process of this adaptations and feasibility study. So I am the Jamal Uddin, PhD research student, University of Glasgow. So today's presentation seminar is the overview of my PhD first, and then the process of the adaptation of the Bangla Heart Manual, and the assess the adapted Bangla Heart Manual and feasibility pilot trial, and barriers, opportunities, and overcome experiences. So here is the project seminar, summary of my PhDs. The overarching aim of this study is to develop an evidence-based adapted home-based cardiac rehab intervention that utilization in low and middle-income country settings with a particular preference for Bangladesh to guide future research and implementation. So to achieve this goal, this doctoral program consists 4 linked research. First research, the adaptation of complex interventions for people with long-term conditions, a scoping review, and then second, adaptation of the heart manual for patients with coronary heart disease in Bangladesh. Then third study, assessment of the adapted Bangla heart manual with patients with coronary heart disease in Bangladesh, a feasibility study. And the last, fourth one is the systematic review and meta-analysis of home-based CR in low and middle-income country, update Cochrane database. So I am very blessed, and I'm very lucky that my first study, my PhD first study, has been published into the Translational Behavioral Medicine Journal, and I think the main point of this study actually, the implications of these studies is to practice this. Scoping review provides a comprehensive and contemporary overview of the practice of adapting complex interventions for people with long-term conditions. And the policy is our findings provide a resource for researchers, policymakers, and practitioners adapting healthcare interventions to new contexts, particularly between low and middle-income countries and high-income countries. And for future development of adaptation methods, guidance require consideration of the needs and priorities of low and middle income country settings. So this study actually really helped me to figure out how to adapt what kind of methodology we used for my adaptation process, actually the Bangla Heart Manual. So throughout this process of adaptation scoping review, I learned a lot how to go forward. The second study, as you know, that adaptation of the Bangla Heart Manual for people for patients with coronary heart disease in Bangladesh. So this is the actually this slide is very important that actually I use these 7 phases on the basis of adapt guidance methodological framework combined with the 11 steps of public health intervention methods and develop the 7 phases to my adapt Bangla Heart Manual. So phase 1, actually the selection of evidence-based interventions. So we selected the Heart Manual English version, English Heart Manual, UK, and this is which is evidence-based worldwide and globally very effective. And then we in the phase 2, we review the original intervention in discussion with the intervention developers. Actually, the original developer of the intervention, as we know, the NHS Lothian. So we discuss with them. I will discuss later on in my presentation that what kind of discussion we did it. And then phase 3 is the map similarities and difference between the original and new context. And the phase 4 is translation and back translation. Forward backward translation is given and adapted intervention materials for preparing the materials. And then phase 5 present and discuss adapted intervention at stakeholder consultation meeting and workshop. We arrange actually 2 meeting. One is expert group consultation meeting, another is the workshop expert group, consultative workshop. So this phase actually very important. We got some ideas, suggestions from them. And then phase 6 is external review of the rapid intervention materials. This phase is actually we focus on the content, language, pictures, understandability, structure of the proficiencies and visual clearances, and also type of materials and mode of delivery. Lots of things we reviewed and adapted the intervention materials. And then finally finalize the rapid intervention materials. Through all of these suggestions, compile and analyze, and then finalize the rapid intervention materials for Bangla Heart Manual. So this is the phase 1, actually the international consensus meeting after deciding that we use the adapted the UK Heart Manual. And I have got the ethical clearance from the Bangladesh University of Health Sciences, where my co-supervisor, Dr. Mithila Farooq and Professor Mashiki was there. And I have got the ethical clearance from them, and we arrange an international consensus meeting with the original developer of the Heart Manual. And at that meeting, we actually get some permission from them that the content of the Bangla Heart Manual, and we present that the Heart Manual, Bangla Heart Manual, would be one single Heart Manual, and by combining the 2 Heart Manual, actually the Heart Manual for revascularization and Heart Manual for post-MI, and also the content would be what the content would be, and how to maintain the core component of this content. So all of these things discussed in this international consensus meeting with them. So followed by we prepared the Bangla Heart Manual to combine of as I said that the Heart Manual Revascularization Edition and the Heart Manual for post myocardial infarction. And then we could say that 10th of November 2023 we organized a expert group consultation meeting at Ibrahim Cardiac Hospital, so where Dr. Mithila and Professor Mashiki supported and helped me to figure out this program. This expert group consultation meeting, actually, we drafted the Bangla Heart Manual, and then before this meeting, 2 weeks before, we sent all of these materials to them, and we asked them to review this and give their suggestions. So at the 10th of October, we arranged this meeting, and they provide their suggestions, and with written and some kinds of discussion on the board in the table, and we made a meeting minutes, what kind of suggestions they give. So this was really very nice and very fruitful consultation meeting. And this meeting actually main focus decision that they advised that we have to prepare 2 heart manual, Bangla heart manual, single heart manual, but 2 version. One is the main reference version, another is the shorter version. The shorter version, their suggestion was that which is very handy, pictorial, very understandable, easily accepted to the patients. So that's why after their suggestions, we prepare the 2 version. One is the main reference version, and another is the for shorter version for the patients to easily accepted and understandable. And then we arranged the consultative workshop at Ibrahim Cardiac also, and which is the main thing was that after their suggestions, we again organize this and update the drafted versions, all of these materials, and we presented. We invited this consultative workshop mostly more focused on the patients and their patients caregivers, and who are the deliver the intervention, mostly physiotherapists, nurses, dietitians, and medical technologists and medical officer also. So this was very interactive session, and we explained what we want to go do in future, and what's our aims, and we prepared this kind of materials for you, for both groups, patients and caregivers, and also for the clinicians, I mean physiotherapists, nurses. So we discussed lots of things over there, and we asked them with a semi-structured questionnaire that we'll give them the all materials to them and give them 15 days to read all of these manuals, and also if they feel any kind of problems or what of their suggestions, we give them the semi-structured questionnaire to them, and then they feedback this, and we compile all of their suggestions after this workshop. So then after all of these processes happened, we finally got all adapted materials, like first one, the main Bangla Heart Manual, and then the shorter version of the Bangla Heart Manual. We also prepare 6 weeks exercise program, which is animated version, and also we prepare the mental health part, mental relaxations, which is audiovisual part, and also walking program for audiovisual part, and another for patients and clinicians discussions, conversations. This is also a visual version. So all of these materials we have been adapted and prepared for my next study. So after completion all of these materials, we arrange the training session. So which is, as you know, I have been trained as a facilitator from NHS Lothian. And this training session actually divided in 2 sessions. One is I was trained the cardiac rehab team in Bangladesh, and Caroline, which is from NHS Lothian, she provide mostly the mental health part to the cardiac rehab team in Bangladesh. So in this facilitated training sessions, we actually introduce all of these materials that have been developed in Bangla, and we trained on them, and how to communicate with the patients regarding this, how to follow up collections, data collections, everything. So I think this facilitated training sessions really help to make a develop of cardiac rehab team in Bangladesh. And then which really helped me to my feasibility study. So my feasibility study summary here is the title of this: assessment of the adapted Bangla heart manual with patients with coronary heart disease and their caregivers in Bangladesh. The aim was assess the feasibility and acceptability of the adapted Bangla heart manual and to explore the change in patients, patient-reported outcome pre and post-test. The design was the mixed method single arm design, and the population was mostly patient with coronary heart disease actually who are planned for revascularization like PCI and bypass surgery at Ibrahim Cardiac Hospital and Research Institute. So actually in my hospital actually Ibrahim Cardiac is where I am working, where the bypass surgery patients admitted for 10-day package, and for PCI patients they are admitted for PCI predetermined. They are admitted for only PCI for 3-day package. So I actually collect them from this time period. So here below is the pathway of the data process of this study, like recruitment and screening and recruitment and then intervention given. Mostly intervention has been given before surgery or before procedure, before discharge actually. Before procedure we collect the baseline data, and after procedure we provide the intervention before discharge. And then patient went to the home, and after that we counting the week 1, 2, 3, 4 and 5, 6. So 6 weeks follow-up we keep in connected with them by mobile phone. Every week we call them from the hospitals and by this way we continue this follow-up, and after this follow-up, after 6 weeks they came to the hospitals and we collect the follow-up data collections. And also we collect some other information like satisfaction level and some interview for qualitative analysis. So this pilot trial's primary outcome is actually the recruitment rate, enrollment rate, adherence rate, and retention rate. So my study has been completed in last week. So the recruitment rate is actually 81%, which is each month 29 patients per month we have been recruited from Ibrahim Cardiac. I think which is impressive, but it is difficult to collect. Enrollment rate is about 16 patients per month, and which is 57%. And adherence rate, actually the 8 weeks follow-up session. From these 8 weeks, before 6 weeks is the main weeks, and before surgery or before procedure there is 1 week, and after 6 weeks there is another session follow-up. These 8 sessions we have been followed, and adherence rate is 75% for the patient's adherence rate, and also for the delivered actually facilitators, their adherence rate is 87.5% per sessions. So, and then retention rate. So we could say that in my study, the 2 patients has been died and 1 has dropped out. The died, the death cause is actually for cardiac arrest. Actually, after bypass surgery, when they went to the ICU, and then the patient then comes out from ICU. 2 patients has been died in ICU after surgery. So we didn't have a chance to give intervention, because we provide intervention after surgery when the patients come from ICU to step down, and then we provide intervention before discharge. So we didn't get any chance to give them. They have been dead from ICU. And 1 patient has dropped out. Didn't collect the any information after go home. They didn't contact with them. So this patient has been dropped out. And 1 patient has been re-hospitalized due to fluid accumulation in the lungs. So here is the secondary outcome is exercise capacity. We use the incremental shuttle walk test, and the baseline we collect 17 patients data, and the follow-up 19 patients. So for baseline, the incremental shuttle walk test, actually it is the distance measurement, meters per It is we got the 91 meters average mean, and follow up we got 155 meters mean distance. I think which is progressive in improving, but we don't have used any comparative studies, so we don't say that which one is the best or not, but the patient's outcome is improved. The patient reported outcome, here we use for the patient reported outcome, we use the heart qual questionnaire Bangla version, and we use the Hertz questionnaire, and also use the EQ5D. But I didn't analyze yet the EQ5D questionnaire, but we analyze the heart qual and Hertz questionnaire. So here is the baseline heart qual. The heart qual has, you know, that the two domain, I mean the subscale, physical subscale and the emotional subscale. The physical subscale, the follow-up session is improved than the baseline, and similarly the emotional subscale, so which is very good. And the Hertz questionnaire, also anxiety and depression, we separately collect the data, and which is also improving. So I think spontaneously, the time being, patients, everything has been improved, but sometimes the mental health part, it is very important that sometimes deteriorate, but here the pre-post data has shown that improved. Here we assess the acceptability measures, patient satisfaction level. We use the patient satisfaction level questionnaire. Actually, questionnaire, that means the this expression related, I mean the satisfaction scoring system. 1 is extremely dissatisfied and 5 is extremely satisfied. So we collect both the patients and caregivers actually one single time for after 6 weeks follow-up. I mean last follow-up, we collect this information from the patients and their caregivers, and both of them giving the mean is the 4 above 4, which is satisfied with the service. Actually, this is we in Bangladesh, there is no structured and evidence-based cardiac rehab program, especially the home-based cardiac rehab program. So the patients was very much overwhelmed and very satisfied with our communication and connection with them, and the materials they got from us. So for this reason, and some of these patients very express their gratitude to us. This very fantastic. So so their satisfaction was like everybody's is above 4 is satisfaction level. And you also use the semi-structured questionnaire, semi-structured questionnaire at the same time the follow-up data collection only single time to assess both the patients and the facilitators understanding of the self-care knowledge and motivation of the Bangla Heart Manual as an acceptability measure. Now comes the main point of this, what kind of barriers I faced throughout the adaptation process. So I here actually sorted out the barriers, like first barrier is communication barrier, then second summarizing the manual. The communication barriers, actually the communication gap, what's my experience is that when we organize external expertise group consultation meeting, so I think my experience is that if we properly communicate and make understand, because most of them are clinicians, so they are super busy with their clear practice. And if we explain them what you want to go, what you want to do, and what kind of information we want from them, if we explain and discuss with them and give them proper idea, so which will help to give the better outcome from them. So this kind of, I think, who are coming into my external expert consultation meeting, most of them are very close to me, and also Dr. Mithila Farooq, which is my co-supervisor. So we catch them and discuss with them, but some of them are not so much connected with us. So we saw that we didn't get proper, very good information from them, suggestions from them. So this is my observation. and then summarizing the manual. So this is one another difficulties I face in my process, that summarize two manual and make it one single Bangla Heart manual. That was a very difficult task, and I would like to give special thanks to Dr. Mithila Farouk and her team to help me to combine this and all of these parts to continue the core components of this English Heart manual. So I think this is very important to make a good team to overcome this. And the linguistic barriers, I think this is very one of the major part that in Bangladesh, actually we don't have a medical book written in Bangla, so we all of use in English. So it is very difficult sometimes the medical term translated into Bangla, and also in a day-to-day conversational language, it is a little bit difficult to translate one language to another and make it culturally adapted. So it is difficult. It was difficult, but I think we overcome, try hard on this area, and we use the linguistic professionals to make this process easier. But I think there is lack of linguistic professionals, or may have, and which is very highly demanded. And then the last third one, data, I mean, suggestion extraction. This is kind of like some of the expertise give the superficial advice, not like more constructive deep solutions. So I think if we provide them the semi-structured or open-ended questionnaire to them, and then we can get more constructive suggestions. Actually, what's our aims to get information from them? We have to give details to them, and then which will help them to prepare themselves to when they deliver the suggestions in the expert group consultation meeting or any kind of workshops to prepare the adaptation process. And then financial and technology. I am talking about my barriers. There's financial and technology. So sometimes technological, if we want to get efficient technology expertise, it is very expensive, and need to have some specific search to appropriate professionals. So I have been overcome through my actually communication, and some of them help me to figure out and they support me to do this animation and other parts, but it is sometimes very expensive. And time constraint, yes, my PhD, there's lots of works, there have lots of time shortage, but I have been overcome through my groundwork and also support from my team, actually from BUH's team, and also everybody's support that helped me to come out from this. And another barrier is the compilation barrier. I think this is I feel difficulties that all of their suggestions, sometimes some suggestions is not properly what my focused on, or my aims. So sometimes very difficult to compile all of the suggestions to incorporate and imply on my process. So it is need to very cautious and focused on what you want to develop. So this kind of barriers I faced through the adaptation process. So now I am discussing about, I want to discuss about the feasibility pilot trial. Throughout this process, what kind of barriers I faced. This is also another same communication barriers. I mean, I could say the gap between the professionals, patients, and their caregivers, clinical professionals. Actually, when we collect data in any hospitals, so it is need to more discussion with the clinicians who are giving support to give the patients to them for this study. So, and the patients from them, they're not open to give all of this information. So I think communication is always important to get better outcome. Especially, and when I get consent from them, it is also difficult part because there's bypass surgery or PCI, any kind of procedures, the patients and the caregivers, family members, everybody is very anxious and stressed time they have been passed. So if you invite or offer them to to introduce any kind of trial or any kind of new kind of intervention, since they are not so easily accepted. And so to overcome this, I use the clinicians. I would discuss with the clinician, but and when the cardiologist or cardiac surgeons advise them, they can easily agree. But sometimes the fearness comes with them. So that's maybe make a problem, but we need to overcome if we use better communications and also involve the clinicians, hospital administration. That can be fine to get more recruitment. And as you know that in my study we use the incubator shuttle walk test as a exercise capacity. So this area I feel really barrier from the patient side and also from the clinician perspective, because of mostly for the PCI patients, the cardiologist, they don't accept any kind of exercise before procedure or even after procedure, 2 weeks, 3 weeks, give them rest. Even though there are lots of evidence that it is it is not is a bigger issue or any kind of problems created, but it is very newly introduced in whole over the country Bangladesh. So it is some kinds of barriers they don't give accept this exercise capacity test. And from the patient side also, they don't sometimes they don't agree to work or doing this kind of test. So this is kind of problem. So we need to do detailed discussion with the clinician regarding patient safety, evidence-based, everything we need to discuss and give them assurance that, yeah, we could do, or we can take all of these measures and then we can overcome this easily. And also the follow-up data collections via phone call. So this is very good device, good technology, but sometimes we lose the patients because of we don't sometimes the patients, when the patients in admitted in the hospitals, we got the number from them, but this number may not use in the later on. So we need to collect multiple number from the patients or also patients caregivers that make sure them that this number is they use when they go at home. So this is also another problem we faced. And then we collect the phone number from snowballing process, like and then communicate. So this is one kind of barrier. And another barrier is that facilitator, cardiac rehab team. I think this is also another important part, that if we develop a good cardiac rehab team, which is they are motivated or dedicated, which helped me to figure out to actually implement the intervention properly and then follow up properly. And I feel barrier or challenges follow-up data collection in hospital. Actually, in the after 6 weeks, when they came to the follow-up data, follow-up in the hospitals, actually they came to the hospitals for their follow-up, routine follow-up. We collect the data. So that time they have a time constraint and lots of tests when they came to the follow-up, lots of physical tests, biomedical tests they have to do for their doctor visit. But if we take some extra time for data collections and also for incubator shuttle walk test kind of this or any kind of this, they feel very stressed and they don't not so much interested, even though they agree with the they give consent for this trial, but sometimes it is bothering for them. I think we may overcome this. Integrate in the hospital routine follow-up in this trial. That could be another solution, that they mentally prepared that when they came to the hospitals for follow-up, they need to do this kind of attend this kind of follow-up data collection process. And finally, the adverse situation, actually the natural or political disaster, sometimes like transportation problems, internet connection problems, or so on. Actually, what I'm saying that in this feasibility trial process time period, I have faced this in, that in Bangladesh, there is we are in the face of political turmoil, and that time patients are not come to the hospitals, and every internet, everything is communication has problems, but mobile phone, this was okay. And we keep connection with them, and they feel very confident, comfortable, and they feel ownership. Like, yes, from hospitals, they communicate with them. So I think this kind of adverse events may happen, but we can think about in as earlier process. And now the opportunities, what I could say that it's a new intervention, especially for country like Bangladesh. So we don't have any home-based cardiac rehab program. Even in the hospital, they don't have any evidence-based cardiac rehab program. Only for bypass surgery patients, we use the intervention for the last this kind of exercise, but not working properly in the mental health part and also other part, the health education part. So I think this intervention is a very good new intervention is a good opportunity for us and also for the patients and the clinicians to introduce properly and also invent properly. It is an opportunity. And then also for the home-based cardiac rehab, I think for the patients and clinicians, it is a great offer for everybody to invite them. This home-based cardiac rehabilitation could be a good options to another interventions. I think that my third opportunity is like this. It can be a like of any hospital's new intervention service facilities they can offer. And the phone call follow-up is a great opportunity to keep connection with the patients, any unusual situations. I think this is also another opportunity to serve the people, serve the patients, and also keep our service with them. And I would like to acknowledge Ibrahim Cardiac Hospital and Research Institute, and also Bangabandhu Sheikh Mujib Medical University, and National Institute of Cardiovascular Disease, National Heart Foundation Hospitals and Research Institute, and all stakeholders, including patients and their caregivers, and also training participants. So I'd like to acknowledge them, and I would like to give my special thanks to Professor Rod Taylor, my supervisor, and also Professor Dr. Mashiki sir and Dr. Mithila Farooq for their cordial support throughout the journey. Thank you so much for being patient hearing. If you have any kind of questions, please ask me. I can try my best. Thank you so much.
Jamal, thank you very much indeed. Do you want to stop sharing your slides, and then we can see everyone, and I can see various claps coming in. So huge well done, Jamal. Wow, what a huge piece of work that was for one individual as part of their PhD. So that first observation. I think the second observation, Jamal, is that it's very reinforcing for across, isn't it? I mean, basically, you've shown that we can go through some of these processes that we're going to be doing at scale in the program. And then last but not least, I think you also gave us some very interesting reflections on what might be learnings when we do go forward with a cross. But enough from me. Any questions for Jamal? If you want to put your actual hand up or your virtual hand up, unmute yourself. Please go ahead. Who's got a question for Jamal?
Yes.
Abraham.
Abraham, yeah.
First taxi off the rank. Off you go.
Jamal, fantastic work. Nice to hear the volume of work that you've done. And it's not easy, believe me, I know, and especially when it's new and it hasn't been done before, it's all the more challenging. Not so much of questions, but probably some thoughts which may help moving forward. I think you've touched upon a lot of interesting challenges, and these are actually what we see as well in many situations. So it's good to have this background because it helps us identify potential challenges moving forward. I was thinking about the problem that you mentioned, or the difficulties that you faced with the incremental shuttle, and the clinical reservations. We don't use the incremental shuttle very often here. We did try it for more stable heart failure and pulmonary hypertension patients, and they've been able to do it. But for CABGs or pre-revascularized patients, we still go ahead with a 6-minute walk. And I think that may be a safer bet. For patients with a little more symptoms, we just do the 1-minute sit to stand. For patients who are even more symptomatic, we consider DASI. So you can have like 3 levels of working, and based on symptoms. Obviously, someone who is coming in for an immediate revascularization, we're not going to touch them. We're just going to keep them there. So class 4 symptoms, angina at rest, we're not going to do anything. But class 3, class 2 anginas, class 3 anginas, you could always do with 1-minute sit to stand. We also have a portable patient monitor, which we can hook up with ECG leads. These are the cheaper ways of doing it, so you don't always necessarily need to have, and these are what are readily available in the hospital. So that is again one way by which you can still monitor ECGs and see if at all they have any untoward problems. You can stop the test, obviously. But if there are still reservations from your clinicians, then the easiest thing is just do the 1-minute sit to stand. And that should 1-minute sit to stand and DASI, because those are two things you can repeat n number of times. DASI, the advantage being they don't even have to come to the hospital. You can do it over the phone, so follow-up data will not get missed. 1-minute sit to stand also, we've been managing to do it virtually for patients who can't come in, and yeah, it does work to an extent. So that may be one way to do it. And post-op also, we do it at discharge, which may be day 5 post revascularization, sometimes day 4, sometimes day 7. As long as they're revascularized, the risk is minimal. But again, I think there are ways to deal with the concerns where it's with the 1-minute sit and the DASI.
Abraham, that's really useful. And just to help everybody who may not be so in the lingo, DASI for people, what does that?
Sorry.
What is it?
So,
no, that's fine. Yeah.
So
what is the DASI? Yeah.
So it's the Duke Activity Status Index. It's basically a questionnaire which estimates exercise capacity. So there was a time where non-exercise based exercise evaluations were a hot topic. So this is one of those things, and it's been shown to correlate quite well.
Yep.
The only challenge I think we may have in our area with DASI is the question with respect to sexual functioning. We do struggle with a few patients not wanting to answer, so that does throw us a bit off, but that can still be addressed culturally moving forward.
Yeah, and so thanks for that, Abraham. Some really important observations about the reality of doing this in practice. And again, I'm just going to throw an idea out there that one of the things we will want to do with our PhD students is identify potential methodological issues, and this might be one of them. In a practical setting, what might be the different ways and the pros and cons of testing people's exercise capacity, and do some validation work. So great comments. Any other comments for Jamal? Anybody else like to ask any questions? Rashki, your hand's up. Go ahead, please. And Rashki, would you like to maybe just introduce yourself, just in case not everybody knows you? Sorry, I should have said that at the beginning to everybody. Go ahead.
Hi, I'm Dr. Rakshi Maman, and I'm based at UCL. Now, I'm working on the burns rehabilitation program as a research fellow. And I'm also really quite wedded to across, because we started off with the theory of change and got to know all of you. So congratulations again. Jamal has done really well. I just wanted to, it's more of a statement rather than a question, is as you said, Rod, having sort of highlighted the challenges and the opportunities, this is going to be really useful going on forward with the cross. And just being an advocate of theory of change, you were involved in it as well. And I just felt that maybe if we would have taken that approach with your study as well, maybe that might have ease some of the problems around communication, stakeholder engagement, and also team working.
Thanks.
And actually, I think that was a common piece of feedback you got when you presented your work to Emma and Alex, as well as having that kind of theoretical basis. So we certainly haven't forgotten it, Rashki. And again, as you well know, delivering a PhD on the ground with all of the operational challenges, as well as some of the theoretical ones, is to be much considered. But you're absolutely right. We need to, excuse the expression, blow the dust off of that logic model we put together and very much bring it to the table in that theory of change, and respect that as we go forward with our research work and across. So well made. Good. I'm conscious we're coming up almost to the hour. So any other questions? Maybe one more question for Jamal. But Jamal, go ahead. Please respond.
Professor Azal Karim sir want to ask, and I give special thanks to Professor Azal Karim sir for throughout the process of trial. Yeah, thank you, sir.
Thank you, Jamal. I have seen your presentation. This is my observation and comment. Most of our patients, Jamal was managing by himself. His team was helping partially because they were not well trained. So because it was a pilot project, so they have some experience now. I think there will be no problem what difficulties he faced in this group of patient, because there was some political problem also, and our team was not so much trained. So in future, I think Jamal will overcome it, and patient-wise will help by giving the patient. I am a clinical cardiologist, and my colleagues, they are also helping. So patient-wise and our team-wise, it will have no problem in future, what I feel. Thank you.
Yes, sir.
Thank you, Dr. Karim. And as you say, I think an absolutely key part of this, intervention is not just the, adapting the intervention, but it's training the staff to deliver that. And as you say, that's going to be absolutely key going forward. And again, I think this is this issue about capacity building. So it's not just about research; it's also about train that healthcare workforce going forward. Yeah, point well made. Jamal, did you want to respond to that? Does that sound familiar to you?
Yeah, I think from clinician perspective, Professor Azal Karim sir personally support me throughout the process of this pilot trial. But I think if we train properly the cardiac rehab team, and also all of this, as I mentioned, that how could overcome, if we discuss with the clinicians and get administrative support from them in the hospitals, it could be easily overcome these barriers. So I would agree with Professor Azal Karim sir. Thank you, sir.
Yeah. Welcome.
And for the purposes of the trial, we'll be able to take advantage of the existing training infrastructure, which we have in UK. Yes, that's delivered in English, but it's a 2-day intensive online training course that's delivered by NHF Lothian. And Jamal, you yourself attended that training, as did your facilitators, and then you helped to support them. So that will be our initial model going forward. But we do need to think about adapting that for our own countries and maybe training the trainer. So when we train up people like Jamal, they can then cascade that training on, and the effect snowballs, and we can do that at scale. So that's going to be a really key part, I think, of the provision of the intervention going forward, is that training infrastructure for the future.
Yeah.
Good. Well, look, folks, I'm conscious that we're coming up to the hour. So I'm just going to share one last slide, if you'll allow me to do so. And it's really just to say just a couple of things in closing. So, as I said, today is very much hopefully the opportunity to provide what's going to be a termly programme of across online seminars. You know, those seminars could be from the team, such as Jamal today. We're going to have a cadre of PhD students we're going to be training. They might want to present. And of course, we could invite people from outside across to come along and teach us some stuff as well. So this is very much hopefully going to be an educational initiative that we can take forward over the next 5 years and try and do maybe 3 or 4 of these a year. So on that theme, if you do have any ideas for either seminar topics or suggested speakers, please do email David and Claire. David and Claire, as you know, David Innes is our across program manager, and Claire Topping is our administrator. And that's our @Glasgow address for the project, maybe note for the future. And then, of course, the other thing is that, you know, if you think that this seminar might be of interest to people outside the Across family, we're very inclusive. So please do cascade future seminar invites to whoever you think might be relevant. And I'm just going to finish up by, again, thanking Jamal for an excellent presentation, you attending. And just to say, we will have our Across soft online launch. So for those of you who are on the project, we're just finalizing with NIH our final contracting. And once we do that, we can then have what would be our official online launch. And we hope to do that sometime in November and December. So do watch this space and we'll update you, and hopefully you can join us for that event. So maybe I'll thank everybody again for attending. Jamal, your presentation. Wish everybody a lovely weekend and hope to see you all soon. Thank you very much.